Hello Doc, I'm your med buddy Arun and I welcome you to my fourth lecture which is part of series of lectures on diseases caused by gram-positive bacteria, and in this lecture I will tell you about Corynebacterium diphtheria. We will talk about microbiology, epidemiology, pathogenesis, virulence, vaccination, clinical features and treatment. So let's get started. Microbiology. Corynebacterium diphtheria is a gram-positive clusters. It forms special clusters that are called palisade clusters or Chinese characters when we see them in microscope. These are non-capsulated, non-motile, club-shaped bacilli. It was first observed by Klebs in 1883. Now, it is cultured on tellurite agar media. By adding colistin and nalidixic acid, we can form a special selective media for this bacteria. And the first culture was done by Loeffler in Robert Koch's laboratory. Epidemiology. There is an increase seen in diphtheria cases from last few years in India. It is a concerning thing. There have been seen many outbreaks in past in Europe, USA, Africa, Latin America, Caribbean islands and Russia. These outbreaks were more massive during winter time. In countries which have poor vaccination are under more threat from this disease. The countries which has vaccinated more than 80% of their population are at very low risk. Alcoholics, immunosuppressed, patients with chronic diseases such as diabetes, 60-year plus, and children between 6 months to 10 years of age are more at risk. During intrauterine line, the IgG antibodies against these bacteria are transferred intraplacentally to the baby, which remains viable only for 6 months of life. And complete immunity for this bacteria is developed only after 10 years. The cutaneous form of Corynebacterium diphtheria is more common in tropics. Now the virulence. The virulence is divided based on tox gene containing strain and tox gene negative strains. The strains which contain this gene, that is tox gene, are the one which can produce diphtheria toxin. The diphtheria toxin then binds to heparin binding epithelial growth factors, and this receptor causes its internalization. After entering into the cell, it divides into two fragments, fragment A and fragment B. The fragment A will bind to the cytosol molecules, which will reduce NAD dependent ADP ribosylation of elongation factor, which will inhibit the formation of vital proteins and will lead to cell death. Diphtheria toxin is 535 amino acid strain, and it is produced right below the pseudomembrane, pharyngeal pseudomembrane, and get absorbed from there into the blood. The lethal dose of this toxin is more than 100 nanogram per kg. Now, this toxin leads to pharyngitis by means of pseudomembrane, systemic toxicity, neuropathic disorders, and myocarditis. The non-tox containing strains are responsible for causing pharyngitis and have been seen these cases mainly in Europe. These causes cutaneous infections and they can become toxic by gaining the tox gene from conjugation method. Now the vaccine. The first vaccine that was a toxoid vaccine was formed between 1926 to 1930 by Roman in Pasteur Institute. and this vaccine was formed as the diphtheria toxin was isolated, was added to formalin, which made the toxin non-toxic but equally immunogenic. On further processing, we got this toxoid vaccine, which was responsible for producing IgG antibody against this bacteria. Clinical features and treatment. Corynebacterium diphtheria can cause both cutaneous and respiratory diphtheria. The clinical features of respiratory diphtheria can easily be confused with corona, gonorrhea, and strep throat. It has features such as strep throat, low-grade fever, adherent nasal and pharyngeal pseudomembrane is seen. What it is? It is a mucosal ulcer with a special coating which has an inner fibrin and outer neutrophilic bands spreading to deeper layer of mucosa, and this pseudomembrane looks initially white, then later turns to gray and then green, which on trying to scratch starts bleeding. The complication that this pseudomembrane can cause is airway obstruction. Also dyspnea, dysphagia, weakness, hoarseness, neck edema, which is a form of bull neck edema, means there is massive edema, massive swelling in tonsils and around the trachea. The foul odor and bleedings in the pharynx can be seen. The toxin produced under the pseudomembrane is toxic to neurons. It can cause neural damage, cardiac damage such as chronic heart failure, arrhythmia, and myocarditis, and later it can also lead to dilated myopathies. The cutaneous form of diphtheria. It is mainly caused by Tox gene negative strains. It causes direct enzymatic damage to the skin, which is a special punched out forms of ulcer, and the pseudomembrane is also seen in this ulcer, which is non-toxigenic. The non-diphtheria corynebacteria, that is the form of corynebacteria which does not cause diphtheria. These are normal flora of our skin. They colonize armpits and certain places over the skin surfaces. They can lead to seeding complications in alcoholics, HIV patients, immunosuppressed individuals, and patients with chronic diseases. This group was formed or separated from diphtheria group based on 16S DNA sequencing. Now the treatment part. If the patient is suspected of diphtheria, it should immediately be isolated, and all its contacts should also be immediately isolated, and all the contacts should be given oral erythromycin for at least 10 days. For diagnosis of diphtheria, clinical findings and lab culture together should go. After that, to the patient which is suspected of diphtheria, equine diphtheric antitoxins should be administered after sensitivity test. These are antitoxin against diphtheria toxin. These should immediately be administered so that the unbind toxin present in the blood can be neutralized. The antibiotic therapy. Procaine penicillin G, 600,000 million units per 12 hours, and in children 25,000 million units per kg should be administered. Then once the patient is started feeling well, and the sign of feeling well is the patient will start comfortably swallowing the food, then we can start oral penicillin V, 125 to 250 mg per 4 hours. Erythromycin, rifampicin and clindamycin can also be given. Rifampicin and clindamycin are basically given in the allergic patients. Erythromycin dose has to be 500 mg IV or 40 to 50 mg per kg IV for the children. Now for prevention, compulsory vaccination in health workers and pregnant women should go. The vaccine available is called Tdap vaccine. Also, once the disease has resolved, again the lab test should be done. If it is positive, then increase the antibiotic administration for 10 more days, and if it is negative, then send the patient for vaccination.